Good morning, everyone. I am Dr. Nithya, working as Assistant Professor in the Department of Obstetrics and Gynecology at Sri Lakshminarayana Institute of Medical Sciences. So today we'll be having a discussion about infertility, more so about anovulatory infertility in specific. Okay. So let's move on to the topic. So first of all, we should know what is infertility to diagnose it at the right time. So infertility is nothing but after 1 year of unprotected intercourse, if the couple is not able to achieve a conception, then they come under the diagnosis of infertility. This is according to the recent WHO definition. Or sometimes RCOG says a broader window because most of the couples these days, they are not cohabitating. So there are many other reasons for a failure to achieve a conception. So they revised the definition. Sometimes they take the criteria as 2 years. That is failure to achieve after regular unprotected sexual intercourse for 2 years in the absence of any known reproductive pathology. So a woman of reproductive age who has not conceived after 1 year of unprotected vaginal sexual intercourse in the absence of any known cause of infertility should be offered further clinical assessment and investigation along with her partner with earlier referral to a specialist if the woman is over 36 years of age. So again, NICE says it depends upon the age of the woman because there could be some teenage woman who will be married for 2-3 years. But that is not an age where we need an urgent intervention. So it basically depends on the age of the patient and the duration of marriage. So NICE combines it both and says sometimes when the woman is over 36 years of age, that means that her ovarian reserve is already going to be less and we need not wait much time. So when after 1 year, we can even refer her for further investigations and management. So here broadly we classify infertility due to different causes. So most of them usually blame the female partner for being the cause of infertility, but it is not actually so. Both the male and the female have equal role. In fact, if you see scientifically, male plays a major role in in the cause of infertility. So if you take female factor, it contributes to 40 to 50% of all the causes that are associated with infertility. Whereas sole male factors, that is only male factors, are responsible for 25 to 40%. And both male and female factors combined together can exist in few couples that will attribute to around 10%. So having said this, there could be some part of infertility couple where you cannot find any cause with both the partners. In such cases, you call them or you term them under unexplained infertility, where you cannot find the cause in both male or the female partner. And if you take the female infertility alone, there are different causes. So overall, the female reproductive system consists of ovaries. The ovulation should happen right at the correct time regularly. And for normal fertilization, the ovum that is released from the ovary has to be picked up by the fimbrial end of the fallopian tube. So the tubal function and tubal motility is also very important. So because if it is just left in the peritoneal cavity, there is no point because the sperm is not going to enter into the peritoneal cavity. We all know that fertilization happens in one part of the fallopian tube called ampulla. So the tube, the ovum has to reach through the tubal motility into the ampulla, and the sperm has to travel through the cervix and vagina without any obstruction or some structural causes can also cause deformity in the motility of the sperm. So these also should be ruled out. For that, intact cervical canal and a regular endometrial cavity is also important. So once the sperm and ovum reaches the fallopian tube and they meet in the ampulla of the fallopian tube, fertilization takes place there. Again, through the tubal motility, the fused embryo has to reach the endometrial cavity. Above all this, the uterus, that is the endometrial lining, has to be very much prepared and it has to be healthy to receive the embryo and for that to get implanted. Okay. And then unexplained infertility, that is any cause that is not known. I mean, all these things, tubes, ovaries, peritoneum, and the cervical canal, vaginal canal, and also the endometrial lining, everything could be normal and still the patient, it could be a female factor that is very unexplained, could be the cause of infertility. And also there is something called miscellaneous causes. Let's see what are those. We know female factors contributing to 40 to 50%, out of which both ovaries and tubal factors are equally important. So to understand the reproductive physiology, we have to know the physiology of ovulation. So this is a chart that explains as a whole what happens during menstrual cycle. So we know that the menstrual cycle has two phases. One is the follicular phase of the ovarian cycle and second is the luteal phase of the ovarian cycle. So follicular phase is mostly under the influence of FSH, and we all know just before ovulation, that is on the 14th day of the cycle, where a woman has normally 28-day cycle. On the 14th day, there is a release of ovum. So you can see in the second part, in the second row of the picture, that the follicle keeps developing during the first half of the cycle, and once it has reached the adequate size, there is a rupture of there is a rupture of the zona to release the ovum into the peritoneal cavity. So that occurs when there is an LH surge. So whenever there is LH surge, we can understand that the patient is going to be ovulating. So there is a gap of 12 hours actually when you take the LH peak. After the peak of LH, the ovulation is predicted to happen in 12 hours. And then when there is a release of ovum, the remaining tissue becomes corpus luteum, and that corpus luteum will get matured to form the corpus albicans, usually when it is not fertilized. Also, if you take the hormone levels, different hormone levels, that is predominantly under the influence of FSH in the first half, and the second half of the cycle is under the influence of LH, that is luteinizing hormone. And if you take the ovarian hormone levels, initial half of the cycle is going to be estrogen and the second half of the cycle is going to be progesterone. So this is very important because we are going to supplement these hormones artificially when you're going to induce ovulation in a patient. So we know that LH surge has to happen if the patient has to ovulate. So for LH surge to happen, she should have adequate amount of FSH in the first cycle. So all these changes that are happening naturally in the menstrual cycle of a woman may not happen if the patient has anovulation due to any cause. So similarly, these are all the changes I told about ovarian cycle. Similar changes happen during the menstruation in the endometrium. So that is called endometrial changes during the uterine cycle. What happens during the first 5 days is the menses, that is destruction of the functional zone. So we all know endometrium has two zones, that is basal layer and the functional layer. During menstruation, what is shed as menstrual blood is nothing but the functional layer of the endometrium that keeps replenishing every now and then. But the basal layer keeps, that is constant. That is where the functional zone keeps developing from after every menses. So proliferative phase is nothing but the first half of the cycle where there is influence of FSH and estrogen. So what happens, whatever is lost gets repaired and regenerated. So there is just the growth of the endometrium that is happening. And then after ovulation, we all know that the predominant hormone that is responsible for the second half of the cycle, that is progesterone, is going to increase. So when you see the second half of the cycle, it is predominantly secretory phase. So there is enlargement of the glands become more tubular and tortuous. So these are the changes that happens in the second half of the cycle. So how can you predict this change from the first half to second half? We have multiple tests that will detect ovulation. So here they have mentioned about basal body temperature, which is a very basic test that every woman can get it done for her at home. So there is a special thermometer which will measure the temperature in small points. So when the woman after menses keeps checking her temperature, on one fine day, there is a sudden rise, that is around 0.5 degrees Celsius, there is a rise in temperature. So that is significant of ovulation. So that means that the patient has ovulated. But what is the disadvantage of measuring the basal body temperature? One, not all the patients are very educated to do it for themselves. So it was not possible for everybody to do it. And second, you know only if the patient has, you know that the patient has ovulated only after it is done. So we do not know whether, we cannot predict that the patient is going to ovulate tomorrow. We can only say that the patient has ovulated yesterday from this basal body temperature method. So that's a disadvantage of this. So we also have other better methods which we will be seeing in the next slides. So I told you about LH surge. LH surge is very important. 36 hours from the surge or 12 hours from the LH peak is the predicted ovulation time and the rise of basal body temperature. Okay, so let's see what happens in natural cycle. Duration of FSH secretion is limited by negative feedback from the estrogen that is produced by the larger follicles. So as I told you in the first half of the cycle, the size of the follicle is going to be increasing. There is going to be a growth and development of each of the follicle. And then these follicles keep releasing the hormone known as estrogen. So that will cause negative feedback on the FSH secretion. Okay. So that FSH is regulated by the negative feedback from the estrogen. So that is going to be limited. And smaller follicles with few FSH receptors are no longer stimulated to grow by decreasing FSH. So those small follicles keep undergoing atresia. So what happens? There are multiple follicles, that is a cohort of follicles keep developing. So only the larger follicles will have multiple FSH receptors, whereas the smaller ones will have only less number of FSH receptors. So when there is less FSH, these smaller follicles will not respond to them and they mostly undergo atresia. The only one big follicle which has a lot of receptors for the FSH will respond and it keeps growing and it reaches the maturation stage. So that is why only a single follicle reaches the maturation stage instead of all the smaller follicles developing. Okay. So this is a normal physiology of how only a single follicle develops. Okay, I told you there are better methods to assess the ovulation. So what are those better methods? When you do a serum progesterone level in the second half of the cycle, preferably it is done on the day 21, that is a week before the expected menses of that woman. It should be at least 3 nanogram per ml because I told you already the second half of the menstrual cycle that the hormone predominantly that is going to be present is progesterone. So when you measure it at the peak of the secretory phase, that is day 21, it should be at least at a minimum level of 3 nanogram per ml, which is an objective evidence that the patient has ovulated. Only if she has ovulated under the influence of LH, she can have progesterone in her serum. Next, ultrasound monitoring of ovulation. So how do we do this? So we roughly have a calculation of the cycle length of the woman from history. So when we have that, you know that the second half of the menstrual cycle is always going to be constant, that is 14 days. The variation in cycle length is only because of the proliferative phase, that is the first half of the cycle. So when you minus or subtract 14 days from the usual length of menstrual cycle, you will get the first half of the length of the first half. So for example, if a patient has 35 day menstrual cycle, we know that the patient is going to ovulate on only 21st day instead of 14th day. So what we do, we start monitoring her for ovulation at least 5 to 6 days before the expected date of ovulation. So let's take a normal 28-day cycle and we know that the patient is expected to ovulate on day 14 of the cycle. So we have to start monitoring her at least from day 10. So call her for an ultrasound. That preferably a transvaginal sonography is what we prefer for monitoring the ovulation, and keep doing it once in every 2 days. So you know that the patient has undergone or ovulation has happened only with 2-3 signs. So what are those signs? One, the follicle keeps increasing, and on one fine day you see that the follicle has disappeared. So that is one sign. If the growing follicle has disappeared, it means that it has ruptured. So ovulation has happened. Second, when it ruptures, there is always some amount of free fluid that is seen in the pouch of Douglas predominantly. And also sometimes you can see a corpus luteum, that is a collapsed follicle you can visualize on an ultrasound. So these three are the signs of ovulation. So this is again a objective evidence of ovulation. Third, this is being commonly used these days because you have the commercial kits that are diagnosing urinary LH surge. So when you predict your ovulation, that means your urinary LH will also undergo a peak. So when you take the urine sample of the women and keep doing it in the kit, one day you will get 2 lines instead of 1 line. So that means that the patient's urinary LH is at a peak level. So from that day, she is going to ovulate in the next 36 hours is the prediction of ovulation. And then basal body temperature, as I explained earlier, it's not very much reliable. And endometrial biopsy, definitely you can do to diagnose definitive evidence of ovulation, but it is not ideal and it is not ethical also to do an invasive procedure when you have so many other non-invasive blood and urine investigations from which you can make out ovulation. So as I told you, out of all the female factors that are contributing to infertility, the ovulatory dysfunction is what we are going to deal with predominantly today. So WHO has classified these ovulation disorders into predominantly 3 groups. Okay. So the first group is hypogonadotropic hypogonadism. That is because there is less amount of FSH and LH from the pituitary, there is less amount of estrogen, and so there is anovulation. So this is predominantly a higher cause. So that is idiopathic hypogonadotropic hypogonadism or Kallmann syndrome, where there is isolated gonadotropin deficiency associated with anosmia. Sometimes it could be functional hypothalamic dysfunction. That is excessive weight loss such as anorexia nervosa, or when the patient is over exercising, stressed out with something, or if the patient is on some drugs that can inhibit the hypothalamic function, and also sometimes iatrogenic when you are giving GnRH antagonist. And it could be some disease that is particular to pituitary gland, like pituitary tumor or an infarct following a PPH, that is Sheehan syndrome. So all these causes come under hypogonadotropic hypogonadism. So basically, gonadotropin are less in this, that is reduced FSH and reduced LH, leading to anovulation. Second, this is the most predominant cause that we see, that is normogonadotrophic, normogonadic ovarian dysfunction, that comes under WHO classification of group 2. That is polycystic ovarian syndrome, that is commonly seen everywhere in all the age groups. If you do scan for 100 women, you can see polycystic ovary in at least 50 women. So you know that this is the very predominant cause, the pathophysiology of which requires a separate lecture by itself. So we know that gonadotropins are normal in this, or there could be only slight alterations in the ratio, but the estrogen is also going to be normal in this, but there is a anovulation. The third group, which is very, very difficult to treat group, that is ovarian failure, that WHO group 3. So here there is primary ovarian failure itself. The problem is with the ovary. In the first group, there is no drive for the ovary. In the second group, everything is happening, but there is anovulation. Whereas in the third group, ovary itself is not functioning, for which there could be many, many causes. One is genetic cause, that is Turner syndrome, or it could be due to autoimmune causes. And sometimes it can follow infections like mumps. Iatrogenic causes, for example, if the patient has received radiotherapy or chemotherapy for some other condition, and also if the patient's ovarian tissue has been damaged during surgery iatrogenically, or even idiopathic. Some women, due to family history, they can have premature ovarian failure at the age of 35 or 40. This is increasingly being seen. So what we know in these cases is the gonadotropins, that is FSH and LH, is going to be very high in these cases. Other endocrinopathies such as hyperprolactinemia, thyroid dysfunction, or any other conditions of androgen excess, such as CAH, that is congenital adrenal hyperplasia, and androgen secreting adrenal and ovarian tumors. All this will come under causes of anovulation. So I told you that the first one, that is hypogonadotrophic, the incidence is only 10%, whereas the second one is very common, that is normal. The slide is wrongly shown, that marker should come for PCOS. So most common cause is 85% of anovulation is due to polycystic ovarian syndrome, and third one usually is less again, that is hypergonadotrophic, where there is complete ovarian failure. The incidence is very less, that is 4 to 5%, but when diagnosed, it is very difficult to treat. Most of the times we ask them to go for a donor oocyte. Okay, so how do you evaluate for anovulation? When a patient comes to you and says that she is infertile, how do you go about it? How do you know which type of anovulation does she have? Okay, from history, if the woman is having a regular cycle, fairly regular cycles, first go for mid-luteal phase serum progesterone. If you think it's anovulatory, that is, if the levels are less than 3 nanograms per ml, then you have to go ahead with this protein. If you think that the woman does not have any regular cycle, she gets periods only in 45 to 60 days. So we presume that it is an anovulatory cycle, and we go ahead with the rest of the protocol. So we take a thorough history and examination in relation to the causes of anovulation. And then we do the basic investigation. So basic hormonal investigation for anovulation includes serum FSH, prolactin, thyroid function test, and a progesterone challenge test. So these hormones are predominantly done, preferably done on day 2 of the menstrual cycle, so that we know what level it has to be. So for example, if the prolactin is increased, then you have to, most of the cases of hyperprolactinemia are associated with thyroid dysfunction. So the next step will be thyroid stimulating, to get the thyroid stimulating hormone done. And if the levels are very high, we have to definitely rule out a pituitary tumor. Suppose the value is more than 100, then you have to get an imaging of the pituitary and diagnose them with hyperprolactinemia. So what you can do, medical management with dopamine agonists like bromocriptine or cabergoline. Sometimes when there is a pituitary tumor which requires surgery, then you have to go ahead with that. And then depending upon the FSH, you have to classify them about whether they belong to WHO group 1, 2 or 3. We know that in group 3, that is hypergonadotrophic hypogonadism, FSH is going to be high. We know all the ovulation dysfunction, they are going to have reduced amount of estrogens. But in the third type, WHO group 3, they are going to have increased FSH because of the ovarian failure. So you have to do the karyotype and find whether there is a genetic disorder. Whatever be the cause, once the ovulatory failure has happened, you cannot take the eggs of the patient for further conception. You have to only depend on the donor eggs for consumption. Second, the most common type of anovulation, as I told you, like in PCOS, you have to check their body weight. So PCOS associated with obesity, definitely there will be anovulation. So if you advise them for lifestyle modifications and weight reduction for at least 5 kilos in 3 months, then you can definitely achieve some amount of ovulation in that patient. And also again, pituitary imaging is definitely required if continuously they are going to have these anovulation irrespective of your treatment of PCOS. So in such cases, you can give them gonadotropins. The first type, that is hypogonadotrophic, where there is less FSH and less estrogen, you can give them gonadotropin in pulsatile doses because FSH and LH are less in these cases. And also you're ruling out the pituitary disorder by doing a pituitary imaging. The third column shows the WHO group 2, which is PCOS, where you have to be careful about their body weight and get a pelvic scan done. So for this pelvic scan is nothing but to rule out polycystic ovarian syndrome. So as I told you, for PCOS, the main mode of treatment is lifestyle modification, where we advise the patient to undergo weight reduction. Second, in these cases, the role of ovulation induction plays a significant role. So you use multiple drugs for ovulation induction, which we will be discussing in detail in the coming slides. So these are examples, letrozole or even insulin sensitizing agents like metformin or gonadotropins, which are second line drugs. And also sometimes surgical interventions are also needed in certain patients, not all cases of PCOS definitely. So what surgical intervention? Polycystic ovarian drilling by using usually a laparoscopy. Okay, now let's go into the details of anovulation. This is type 1, that is WHO group 1. Ovulation induction with exogenous gonadotropins. So I told you these patients are going to have less FSH and less LH. So you have to supplement them in a pulsatile fashion like how it happens in a natural cycle. Because if you give them clomiphene citrate, it is not going to be effective. So this clomiphene citrate's mechanism is to increase the FSH secretion. But with these patients where the pituitary is defective due to some cause, even if you give clomiphene citrate, they are not going to have that negative feedback mechanism and their FSH is not going to increase. So instead, directly give exogenous gonadotropin. So that is intended to stimulate the normal cyclical ovulation. So when you give the gonadotropin, it acts on the ovum just like how it acts in a normal cycle, physiological cycle, and there will be release of estrogens and progesterone. Ovulation will happen. Drug of choice is nanotropin, which contains both FSH and LH. Follicular growth and oocyte maturation can be successfully stimulated by FSH alone. But LH is also required for normal steroidogenesis, luteinization, and ovulation. Endogenous LH levels are typically inadequate in these patients. So when you are supplementing, you have to supplement both FSH and LH, or only the maturation of the oocyte will happen, but the normal luteinization and ovulation will happen, which is necessary for conception. Okay, hypogonadotropic hypogonadism. This is the same thing. What we usually respond to is relative low doses of gonadotropin stimulation. What is your objective always when you are inducing ovulation in a patient? It is not to achieve multiple ovulation in the same patient. It is only to achieve unifollicular ovulation, like how it happens in a natural cycle. Hypogonadal women are otherwise normally fertile. So that's what you should remember. They are usually normally fertile. Only thing that is deficient is FSH. So they are at a higher risk of developing multiple pregnancy when you're supplementing FSH. And also we have to supplement them with HCG, that is 2000 to 2500 international units every 3 to 4 days, because they will have LH surge. This luteal phase support will compensate for the low levels of endogenous LH. It will also improve the cycle fecundity, but it increases the chances of OHSS, that is ovarian hyperstimulation syndrome. So there is a risk and there's also a benefit. Okay. The second one is hyperprolactinemia, that is secondary hypogonadotrophic hypogonadism. Up to 30% of women with polycystic ovarian syndrome can exhibit mild hyperprolactinemia. So it is usually an association that is seen with PCOS. What is the treatment of choice? Definitely dopamine agonists, which are going to reduce the level of prolactin. It is very highly effective in women who are symptomatic. So some people may have elevated levels of prolactin when you are investigating them, but they may be asymptomatic. But few of them have symptomatic galacturia. So these dopamine agonists are very effective in those women. We have to start with a very low dose and increase it gradually. You have two options of drugs. One is bromocriptine, and another one is cabergoline. Bromocriptine is used at a dose of 1.25 to 2.5 milligram HS, that is once a day dosing. And cabergoline is usually used at a dose of 0.25 milligram twice weekly. So at least for 4 weeks, these are given. Side effects, it could be orthostatic hypotension, and other mild side effects that are seen are adrenergic side effects, dizziness, nausea, vomiting, and nasal stuffiness that are commonly seen with these drugs. Moving on to the last type, that is hypergonadotropic hypogonadism. So if you see this cycle, it shows the normal HPO axis, that is hypothalamus, that releases the GnRH, gonadotropin releasing hormone, that will act on the anterior pituitary. Anterior pituitary will release gonadotropin, that is nothing but FSH and LH, that will in turn act on the ovaries to release estrogen and progesterone. So we see that there is a negative feedback at every level. Estrogen and progesterone can inhibit the pituitary, and FSH and LH can also inhibit the hypothalamus. Okay, so this if you understand that the ovaries are failed. So if there is an ovarian failure, there will be less amount of estrogen and progesterone. So that will not cause a negative feedback. So FSH and GnRH is going to be increased because there is no negative feedback. 4 to 5% of the cases of anovulation are due to this ovarian failure. Primary causes, primary ovarian insufficiency, that is early menopause. Or sometimes there could be ovarian resistance where there is a receptor defect. In such cases, ovaries are functioning, but the FSH receptors on the ovaries are not responsive to the FSH that is being released by the anterior pituitary. Many of them have amenorrhea, and usually they do not respond to the therapy for anovulation. Because if the ovaries are failed, there is no point in stimulating the ovulation. They are not going to respond. So most of these patients usually prefer to go on, the treatment of choice would be IVF, that is in vitro fertilization using donor oocytes. They have a high success rate. If they go for donor oocytes and get the IVF done, their endometrium is going to be receptive. There is nothing wrong with the endometrium. So they have a high success rate. Okay, this is the major group that we are going to see in everyday practice. So if you see normogonadotropic normogonadism, withdrawal bleeding with progesterone is seen in these cases. So most of the cases when they come with amenorrhea to us, we first give a progesterone challenge test. That is, we give a short course of progesterone, 10 milligram BD or 10 milligram OD for 5 days, and challenge the endometrium. So the concept is, if the endometrium is estrogenized, so if there is release of estrogen and there is only anovulation and progesterone is deficient with the exogenous progesterone that you have given, the woman should menstruate. So that is the concept behind this. Most of them usually have a withdrawal bleeding with the progesterone that you give. Serum, FSH, LH, prolactin, all the other hormones are going to be normal in these cases. And we know that the most common etiology that we see for this type of anovulation is PCOS, that is polycystic ovarian syndrome. Around 70% of the cases are due to this. And the second cause that we see is luteal insufficiency. And this criteria, Rotterdam criteria, is used since long for the diagnosis of PCOS. Out of these 3 criteria, any 2 should be present to diagnose as polycystic ovarian syndrome. One is hyperandrogenism. Features of hyperandrogenism, where you look for hirsutism or serum testosterone level. Hirsutism is diagnosed by using Ferryman score when it is more than or equal to 9, and the serum testosterone level more than or equal to 0.6 nanograms per milliliter. And oligo or anovulation. So sometimes the patient may come and tell you that she has irregular cycles. So with the history itself, you can predict. And the ultrasound picture, polycystic ovarian picture, in that follicle number should be more than or equal to 12, with each of the follicular diameter being 2 to 9 mm. And the ovarian volume also should be more than 10 millimeter cube. So all these criteria, any 2 of the 3 criteria must be present to call it as polycystic ovarian syndrome. So what is the mechanism in this? Inability to generate the LH surge in response to an estrogen challenge, lack of maturity at puberty, failure of the positive feedback that usually occurs, interference by ectopic steroids. If the patient has taken it for some conditions like adrenal hyperplasia, if she was given a course of adrenal androgens or progesterones, or it could be due to dysfunction of the follicle maturation itself, when there is premature acquisition of LH receptors or relative lack of FSH at a critical point where it needs, failure of the follicle rupture, inappropriate LH search, or drugs, that is NSAIDs, clomiphene citrate, or progesterone antagonist. All this can contribute to the normogonadotropic anovulation. Next, so for these group 2 ovulation disorder, what is the first line of management? We definitely advise women with WHO group 2 anovulatory infertility who have a BMI of 30 or over to lose weight. So as I told you, any patient with ovulation who is obese, then definitely you have to advise them for exercise and dietary modifications. Inform them that this alone may restore ovulation, improve their response to ovulation induction agents, and they have a positive impact on pregnancy outcomes as well. So you have to give them some time, minimum of 3 months for lifestyle modification before you start inducing them with other drugs. So what are the advantages? Definitely it is going to help them for better pregnancy outcome, and also if they are not going to ovulate with this, the next step that you're going to do is ovulation induction, for which there will be a better response if the patient has lost some amount of weight. Next, offer women with WHO group 2 anovulatory infertility one of the following treatments, taking into account the potential adverse effects, ease, mode of use, the woman's BMI, and monitoring that is needed. So we have a lot of ovulation inducing agents, that is clomiphene citrate or metformin or any combination of them. For women who are taking clomiphene citrate, we should offer ultrasound monitoring at least during the cycle of the treatment to ensure that they are taking a dose that minimizes the risk of multiple pregnancy. Again, we should not continue the treatment for longer than 6 months. Women prescribed metformin should be informed of the side effects associated with its use. So metformin definitely is a wonder drug for insulin resistance, but then it has its own side effects. Many of them don't tolerate it. They have poor nausea, vomiting, and metallic taste, gastrointestinal disturbances. All these are seen with metformin. So what are the types of ovarian stimulation that we can do? One is substitution therapy, like we saw for WHO type 1, where there is deficiency of FSH LH, so we are going to supplement them with FSH and LH. Second, use of medications to stimulate development of one or more follicles in a dysfunctional cycle. That is like what we do in type 2. And third one is controlled ovarian hyperstimulation. So this is mainly used for IVF cycles, production of many mature follicles in one cycle that is triggered by medication. So what is the philosophy of ovulation induction? Usually monofollicular and ovulatory. And a small number, that is 1 to 4 follicles for superovulation, and multifollicular, that is for IVF and ICSI, we have to target multifollicular development, that is controlled ovarian hyperstimulation. So before you start treatment with ovulation induction, what is the basic evaluation? Semen analysis definitely is necessary, because there is no point in inducing the ovulation of a patient whose partner's semen is not having adequate concentration of semen. So HSG, as you know, it is a test of tubal patency. So without, I told you the importance of an intact fallopian tube and tubal motility for conception to happen. So definitely you have to check for tubal patency. For 1 or 2 cycles of ovulation induction, you need not check the tubal patency. But if you feel that the woman is ovulating normally and still not conceiving after 2 to 3 cycles, you definitely need a tubal patency test. Third, hormone assay. So these are the basic hormones I told you: FSH, LH, thyroid function test, and prolactin. That is preferably done on day 2 of cycle along with ultrasound. That is transvaginal ultrasound. In certain cases where you think there could be other associated disorders like PCOS or endometriosis or pelvic inflammatory disease or any other uterine malformations that you're suspecting, you definitely can support your diagnosis with diagnostic hysteroscopy or laparoscopy. Okay. For type 2, first line of management is lifestyle modification. Second, we have medical management. We use drugs like SERMs, that is selective estrogen receptor modificator. This clomiphene and tamoxifen are part of those. Aromatase inhibitors like letrozole and anastrozole are also used. There are other adjuvant agents where we use dexamethasone, insulin sensitizing agents, metformin, myoinositol, and N-acetyl system, dopamine agonist, FSH and LH, or FSH alone or LH alone. So all these preparations are available as urinary and recombinant forms. Finally, there are also surgical managements where we do laparoscopic ovarian drilling. So lifestyle modification, as I told you, it's a fertility fitness program. At least 5% of weight loss. Many of them, at least 90% of them, ovulated only with this weight loss program, and 25 of them have achieved the pregnancy with this. And sometimes they also reduce the androgen levels and they get resumption of menses in a patient who has amenorrhea or irregular cycles. They increase the SHBG levels, decrease the insulin levels, and they also have a long-term effect, that is improvement of ovarian function in general. Okay, weight loss, exercise, and lifestyle modifications. This is the SOGC guideline, which says it is effective in restoring the ovulatory cycle and achieving pregnancy in overweight women with PCOS. That should be the first line option. And obesity associated with anovulation, pregnancy loss, late pregnancy complications, and also it could also lead to a failure of infertility treatment. So 5% weight loss before treatment definitely has a positive outcome on both your treatment and the pregnancy state. Obese PCOS, first line of management is lifestyle modification. Okay. What about clomiphene citrate? It is both estrogen agonist and antagonistic property. So it is considered as a competitive estrogen antagonist. The isomers are not important for you. So maybe you can know that the more potent isomer is N-clomiphene. So that is what we use for ovulation induction action. So what is the mechanism? It basically acts by depletion of estrogen receptors in the pituitary and hypothalamus due to prolonged stimulation. Estrogen feedback loops get interrupted, and so FSH secretion is increased, leading to multiple follicles growth. So this is used at a dose of 50 mg, 100 mg, and even up to 150, 200. I have not seen, or it has been very, very rarely used because it has a risk of causing hyperstimulation and multiple pregnancies. So you always start with the lowest dose that is possible, 50. And when you feel that the patient is not responding, that is, she is not achieving ovulation with that, you can increase up to 100 or 150. But beyond 6 cycles, it is not definitely recommended. So when you diagnose treatment failure, what are the causes of treatment failure? It is increasing age and duration of infertility and also obesity. We know that BMI more than 35, definitely the success rate is going to be less for ovulation inducing agents. So what are the problems with clomiphene citrate? It is a long lasting action. So the actions of which last till 14 to 22 days. I told you it has an anti-estrogenic action also. So its effects are usually adverse on the endometrium and cervical mucus, though it is favorable on the ovulation. So next, side effects. Minor side effects like nausea, vomiting, hot flashes, and hair loss could be observed in few people. Iatrogenic luteal phase defect is also caused in this. So you have to give a luteal phase support in patients whom you are giving clomiphene. And clomiphene resistance and failure are two terms that we are going to deal with. So clomiphene resistance is nothing but after giving the dose for at least 3 months, maximum dose, if the patient has failed to achieve ovulation itself, then it is resistance. And failure is nothing but the patient is actually ovulating with the drug that you are giving, but it is not intending the purpose. That is, she is not getting pregnant. She is not achieving a conception with the ovulation. That is failure. Side effects, as I told you, they can have mood swings, vasomotor flushes in around 10%, visual disturbances, including blurred vision, double vision, scotoma, light sensitivity, generally are uncommon, but it is still seen. And if seen also, it is usually reversible. And this is a common side effect, that is multiple pregnancy, at least 8% are noted. Congenital anomalies, there's no evidence. And there is miscarriage rate is also not different from any of the spontaneous conceptions that we see. OHSS is mild, but of course, increased than spontaneous conceptions. Ovarian cancer, definitely not associated with ovarian cancer. This is the observation that is made from different studies. So I told you resistance is nothing but after 6 months of treatment, if the patient is not ovulated yet. It is seen in 10 to 30% of the cases. The prominent causes are obesity and hyperandrogenism. How do you treat them? You can either give an extended course where you give clomiphene citrate starting from day 2 to day 6, usually only for 5 days. In such cases, you can give for an extended period, that is 7 to 10 days, or you can add them with one of the adjunct agents like glucocorticoids, that is 2 mg per day, or 0.5 to 2, depending upon the amount of resistance, you can add it. Metformin or any other insulin sensitizers, gonadotropins, or support them with laparoscopic ovarian drilling. Failure means they are ovulating but no pregnancy for at least 6 to 9 cycles after trying. Causes, again, if the cervical mucus is inconsistent or if the endometrial growth and development is not good, elevated LH. Again, in these cases, you can either do an IUI or you can change the group of drugs and give them aromatase inhibitors, and also you have to give them a good luteal support. So what you can do, you either, if there is no urge to conceive, to reduce the amount of LH and androgen levels, you can give oral contraceptive pills for 6 months followed by ovulation induction. So that significantly reduces the amount of LH and androgen levels. Okay. So other ways are to suppress the FSH and LH. LH levels falls and patient becomes responsive, more responsive to CC. So first line is lifestyle modification followed by clomiphene citrate. Second line, you can add more potent agent, that is gonadotropin. And finally, if they don't respond, you have to go for IVF. Metformin is nothing but an insulin sensitizing agent, category B. So anovulatory women who are not responding to CC alone, or if they are very much obese with BMI more than 25, or if there is associated hyperinsulinemia, these are the indications where you add metformin along with ovulatory induction agents for infertile patients. As I told you, it has its own side effects, one of which is very severe, that is lactic acidosis, that is not commonly seen. And you usually start with a lower dose, that is 500 milligram OD, but you can go maximum up to 1 gram BD. Okay. We all know that it is slightly better than placebo in inducing the ovulation. N-acetylcysteine again is a recent, over a few years, it has been identified as a agent that is helpful in PCOS, mucolytic agent, and it has an insulin sensitizing property. So it's again an adjunct therapy in PCOS who are resistant to clomiphene citrate alone. But we have to note that it is not associated with an increased clinical pregnancy rate when compared with placebo. So not mainly used for ovulation induction. So the next commonly used group of drugs is aromatase inhibitors. So we will see how it acts. FSH stimulates the granulosa cell, LH stimulates the androstenedione production by PICA cell. So what is the role of aromatase? It converts this androstenedione into estrogen. The mechanism of action, it inhibits the aromatase in ovaries and peripheral tissues. And negative feedback being active stimulates the hypothalamus pituitary axis. GnRH release produces FSH. FSH mediated stimulation of follicle, and rising estrogen level from follicle suppresses the FSH, leaving a single dominant follicle. So the commonly used agent among the group of aromatase inhibitors is letrozole. It's used at a dose of 2.5 milligrams. Maximum 5 and 7.5 have also been used. Again, it is used from day 2 to day 6. Again, extended regimen also is there where we give it for 10 to 12 days. So normally used doses of 5 milligram. In cases of where you think that it is not responsive, higher doses up to 7.5 is acceptable. Ovulation rates are 75%, pregnancy rates are 25%, and multiple pregnancy rates are 4%. So it is useful in cases of PCOS and clomiphene resistant, clomiphene citrate failure, and as a combination with gonadotropins. So these days there is a rapid shift, from days of clomiphene citrate to days of letrozole, because there are two advantages. One, it is free from estrogenic side effects, that is anti-estrogenic side effects. It does not have any negative effect on the endometrium or on the cervix. And second, it has a very short half-life of 45 hours when compared to clomiphene, which has a longer half-life of 5 to 7 days. So it gives a more favorable environment for implantation, and there is reduction in the incidence of miscarriages. Third, so these are second line agents. When the patient do not respond to the first line drugs like CC or letrozole, you can go for gonadotropins. So these are used in fact in all the types of anovulation, group 1, 2, and 3. And they are also useful in IUI cycles. So you have two types of preparation. One is the urinary preparation and second is the recombinant one. This is the recent one, that is recombinant DNA technology, that is produced in limitless quantities. Whereas the urinary one is nothing but it is produced from the urine of menopausal women. So it is definitely has some contamination. You can have some amount of contamination, whereas this recombinant is completely pure. So it is, and it's also very expensive because it uses a hi-fi technology for its production. So this again has multiple regimens. You can either give it a step-up regimen or step-down regimen. Usually started on day 2 at a dose of 75 international units and slowly stepped up like 37.5 international units every week, maximum up to 225 international units. And you keep monitoring the follicle size, and when it reaches around 18 to 20 mm, you give injection HCG for the trigger. Or there is something called step-down, where you start with a higher dose, like it happens in a natural cycle, 150 for 5 days, and then slowly reduce the dose. And similarly, when the ultrasound shows a follicle of 18 mm, you again give HCG. Okay, what is the difference and why are you using this? As I told, step down is more physiological. You can use it for CC resistant PCOS, whereas step up is more associated with the monofollicular stimulation, so it is beneficial in PCOS. Advantage is that reduces the amounts of cost and it avoids multiple pregnancy in step up, whereas in step down, with the incidence of OHSS is very, very less. Again, the disadvantage of step up is that sometimes you may get failure, and so you need to cancel the cycle. Whereas step down, it increases the risk of multiple gestation, though there is a less amount of OHSS. So the monitoring is same. Whatever kind of induction that you use, you have to definitely monitor with ultrasound to exclude the functional cyst after 4 to 5 days of gonadotropin. Repeat after 1 to 3 days according to the follicular growth. You have to also look at the endometrial thickness and pattern. What are the contraindications to gonadotropin? Primary ovarian failure, uncontrolled thyroid and adrenal dysfunction, organic intracranial lesion or a undiagnosed abnormal uterine bleeding, ovarian cyst or enlargement, prior hypersensitivity to them, sex hormone dependent tumors of the reproductive tract, or pregnancy. So these are the contraindications for use of gonadotropin. So exogenous GnRH usually is given in a pulsatile fashion, like I told you. For type 1, the indications are mostly type 1 and hyperprolactinemia. So it's given at a low dose, 2.5 to 5 micrograms per pulse at constant interval every 60 to 90 minutes. Okay, for all ovulation induction, I told the common disadvantage is the luteal phase defects due to inadequate LH surge. So it's more associated in these cases, that is hyperprolactinemic patients, recurrent spontaneous abortions, endometriosis, hypothyroidism. All these are associations of luteal phase defects. So how can we treat them? We can either give micronized progesterone or dihydrogesterone at doses of, if you're using micronized, it should be at a dose of 200 milligrams per day, or if you're using a dihydrogesterone manufacturing, you can give 10 milligram twice a day throughout the second half of the cycle. So the last one is the surgical management, laparoscopic ovarian drilling, which is not being preferred as a first line of management anymore. It is only used in CC resistant PCOS. It is not a first line. Benefits are only transient to reduce the amounts of LH and FSH ratio and reduce the amounts of androgen. It has no effects on insulin levels. So what we do, The picture shows it all. We make 4 punctures using a cautery, 40 watts, and the 4 punctures should be away from the fallopian tube, and it should not be less. I mean, it should be only for 4 seconds, and 4 and 40 watts. Okay. The disadvantage, definitely there is some amount of diminished ovarian reserve, and following a surgery, there could be some adhesions which will also affect the conception. So it restores ovulation in 50%. Rates of conception are usually better 50% over the first year. So when you do a drilling, you have to immediately tell the patient that the chances of conception is highest in the first 6 months after the surgery. So get your ovulation induction done by then. Okay. The advantage definitely when you compare to medical things is there is no risk of OHSS and no risk of multiple pregnancy. Intensive monitoring is not required also, like we do for gonadotropin or CC. Best suited for those whose frequent ultrasound monitoring is impractical. Okay, in general, we have already discussed that the risk of ovulation induction includes multiple pregnancy, that is maximum seen with gonadotropin around 25 to 40%. Definitely, you should avoid cycle cancellation. I mean, you should advise cycle cancellation when there are more mature follicles. So you always aim only 1 or 2 follicles. When you see 3 or more mature follicles, you advise for cycle cancellation. Risk of OHSS, it's an iatrogenic complication. You can see in the picture that there is supraphysiologic ovarian stimulation, most commonly seen with gonadotropin. When you see that large number of intermediate sized follicles around 10 to 14 mm and rapidly rising estrogen levels. So how can you minimize? You should use the lowest dose of HCG and also GnRH agonist. This is again divided into mild, moderate, severe, and critical depending upon the size of the ovary, clinical symptoms, and the blood investigations. So in stage 4 or critical, there is TENS, ascites, oliguria, thromboembolic phenomenon, and renal failure. So we know ovulatory disorders contributes to 15% of infertile couples. Around 70% of them belong to group 2, that is normogonadotrophic normovianism. So what is the ultimate goal of your ovulation induction? Not to stimulate multiple follicles at a time. So only monofollicular development is the goal. Again, CC still continues. There is a debate whether CC or letrozole is a good choice, but it depends upon the totally on the gynecologist's choice. And insulin sensitizers are good adjuvants. Gonadotropin induced cycle should be always second line, should not be used as first line. And when you're using it, it needs strict monitoring to avoid OHSS. Low dose step-up protocol is more cost effective. Drilling should be only reserved for cases who are resistant to clomiphene citrate. Thank you.